Welcome back, everybody, to the next episode of Pathagonia. So today I'm going to continue with the cytology section of Kurt's notes, and after this one, and then I'll do one more on urine cytology. So I'll make a quick video on the Paris criteria, either from Kurt's notes or something else, and then I'm probably going to move on to either GI or another system and continue rocking with working my way through Kurt's notes. So today we're going to talk a little bit about neck lesions. So the neck lymph nodes are divided into separate levels. So we have level 1, which is the submental and submandibular region. And the source of the metastases to the level 1 lymph node is from the oral and nasal cavities. And that makes sense if we think about it just anatomically and how close the mouth and the nose are to the level 1 lymph nodes. Moving on to level 2, that's going to be the upper jugular. Level 3 is the mid jugular, and then level 4 is the lower jugular. So you can see we're working our way along the jugular vein, and that makes sense, right? 2 upper, 3 mid, 4 lower jugular. And the source of metastases to this region, as you would imagine, is variable. So many sites can metastasize, and it can't really be pinned down to a single source of metastasis. And then for level 5 of the lymph node levels is the posterior triangle, and level 6 is the anterior central compartment. So source of metastases to level 5, commonly from the nasopharynx, oropharynx, and the scalp. Again, kind of broad, not totally specific. And level 6, lymph nodes, common metastases to that area is from the thyroid and the larynx. And again, that just makes sense based on anatomy, right? And here, for our regional landmark, we have our SCM, or our sternocleidomastoid. All right, next section, we've got our developmental lesions. The first developmental lesion is very common, so a thyroglossal duct cyst. And a thyroglossal duct cyst is persistence of the thyroglossal duct, and it is often midline. Key feature, often that'll come up on a test question or in practice. So these are commonly midline, often attached to the hyoid bone, and usually will present as a painless mass unless they're infected, and then they can become more painful. And they're usually lined by respiratory epithelium, sometimes squamous, and they may have thyroid in the tissue in the cyst wall, as we see over here, thyroidization. And treatment for a thyroglossal duct cyst is resection, and that's known as the cyst trunk procedure. I did not know that. Moving on, we've got the branchial cleft cyst. So these are congenital malformations of the branchial apparatus, and they can come to attention at any age, but often occur in young adults. And these are going to be found more laterally. So branchial cleft cyst, lateral, thyroglossal duct cyst, typically midline. And a branchial cleft cyst is often near the anterior sternocleidomastoid, and it's usually a non-tender mass. Again, unless it's inflamed, then it can become painful. And as we see here, it's usually lined by bland squamous epithelium and rarely has a glandular lining. The wall often has abundant lymphoid tissue, often with germinal centers. So you can appreciate a lot of lymphocytes, which is commonly seen in branchial cleft cyst. You can also have branchial cleft sinuses and fistulas, and you must exclude squamous cell carcinoma metastasis, especially if the patient is over 50 years old. All right, moving on, we've got thymic cysts. And thymic cysts have a wall that contains thymic tissue. Often easiest to see is Hassel's corpuscles. And thymic cysts are lined by cuboidal or columnar or squamous epithelium. Usually occur in kids, and usually the anterior cervical triangle, and may see associated parathyroid. And again, with the thymic cyst, you have the wall that contains thymic tissue, which is what we're seeing here. often easiest to see is Hassel's corpuscle, which is what the arrow is pointing to. Moving on, we've got bronchogenic cyst. So a bronchogenic cyst is lined by respiratory type epithelium, and the cyst wall contains mucoserous glands, cartilage, smooth muscle, and scant lymphoid tissue. Usually occur in kids. They can be midline near the sternum and may compress nearby structures. And we can appreciate some cilia here on that respiratory type epithelium on our bronchogenic cyst. Next up, we've got cutaneous cysts. And cutaneous cysts can occur as epidermal inclusion cyst, which is a unilocular cyst lined by squamous epithelium with a granular layer. And lumen contains abundant laminated keratin. It may rupture, leading to acute granulomatous inflammation. And EICs, or epidermal inclusion cysts, are very common in adults, and these are going to be cases that you'll learn to love on search path sign out because they're benign and they're usually rather quick. And also you can have a dermoid cyst, which histologically is the same as an EIC, but has associated adnexal structures like hair follicles and sebaceous glands, which is what we're seeing here, these sebaceous glands, which the arrow is pointing to. And they're usually on the face of children and along embryonic closure lines. All right, next up we've got lymphangioma, which lymphangioma is a benign vascular lesion that may recur, and it's a localized collections of dilated lymphatics, as the name would suggest, right? Lymphangioma sounds like it's going to involve the lymphatics. It can have variably thick walls and often has lymphoid aggregates, which is what we see here. And it can be lined by flattened endothelium, which is also what we're seeing here. It can have smooth muscle or fibrous tissue, the lumina empty or with proteinaceous lymphatic fluid. And as far as IHC, it's going to be positive for D240 and PROX1, CD31, and plus or minus CD34. Lymphangiomas are usually in kids and infants with variable locations, but most often in the posterior head and neck, and they can be associated with Turner syndrome or cystic hygromas. All right, moving on to infectious lesions. So we can have reactive lymphoid hyperplasia, which is what we see here in the image to the right. And that's going to be a proliferation or collection of lymphoid cells in response to nearby inflammation or infection. Common causes in the head and neck are upper respiratory tract infections and dental infections. And that makes sense, right? If you have some kind of an infection, our lymphoid tissue is obviously involved in our immune system and protecting us from infections, so that you would have a reactive or a hyperplastic, revved up lymphoid tissue makes a lot of sense to me. So you're going to have intact lymph node architecture with separated follicles with open sinuses and polarized germinal centers and mantle zones, as well as prominent mitotic figures and heterogeneous cell population. So heterogeneous cell population is important because if it was a monotonous cell population or composed of predominantly the same cell type, we may be more concerned of a lymphoma or some kind of hematolymphoid malignancy. But if it's a heterogeneous population and composed of various cell types, we're less concerned. Or we can be more confident that maybe it's just a reactive or hyperplastic process, which would be good for the patient. So on FNA, you can often have very cellular aspirate in reactive lymphoid hyperplasia with a mixture of small and large lymphocytes with a range of maturation with a predominance of small lymphocytes, which is what we see here, right? Predominantly small lymphocytes that I'm pointing out. We also have some larger ones, so it's a mixture, but mostly small lymphocytes. And you can have frequent plasma cells and tingible body macrophages. And if you see this, consider sending for flow cytometry, right? So if you're at an FNA, you're going to want to put some of that tissue into RPMI so you can send it to flow. Another infectious process you can have is an abscess. So an abscess is really just a large collection of neutrophils, which is what we see here, right? All these polyballs or neutrophils, and also what we're looking at down here as well, and some of which may be degenerating, some of the neutrophils. Abscesses can also have necrosis and fibrin or fibrinopurulent debris, as well as macrophages, bacteria, foreign material, granulation tissue, and chronic inflammation. And send for culture if you're doing an FNA and you see an abscess, because obviously if we see an abscess, we're thinking some kind of infection, right? So you're going to want to send off for culture, see what kind of bugs are potentially causing this abscess. This abscess can often be caused by bacteria, and sometimes actinomyces can be the culprit. And abscesses in the neck region are often associated with poor dentition. All right, next up in the infectious lesions, we've got granulomas. So granulomas are well-formed collections of histiocytes and multinucleated cells, and they may have central caseating necrosis. So your main differential diagnosis when you have a granuloma is sarcoidosis, Mycobacterium tuberculosis, Bartonella henselae, and fungal infections. So don't forget to get your bug stains. All right, one more infectious lesion, and then we're going to move on to neoplasms. So the last infectious lesion we're going to talk about is mycobacterial spindle cell pseudotumor. And this is a pseudo-neoplastic spindle cell proliferation, almost exclusively in the setting of HIV, that presents as a firm mass. So a mycobacteria spindle cell pseudotumor is going to be a cellular proliferation of storiform spindled cells, which is what we see here, all of these spindled cells, with effacement of lymph node architecture. So the special stains are the phyte, AFB, which highlight organisms, because it's a mycobacterial stain, usually caused by Mycobacterium avium intracellulare, which, as we all know, has an association with immunosuppression or HIV patients. And what IHC would you want to get for a Mycobacteria spindle cell pseudotumor? Well, that's going to be CD68 positive or Vimentin. S100 can be plus minus, Desmond, SMA, and CD31 and CD34 are going to be negative. But your money is going to be with your CD68 being positive. And the treatment for this is to just treat the infection. All right, moving on to neoplasms of the neck. So as we talked about earlier when we were talking about the lymph nodes and the various levels, we can have metastases from various sites. So you can have metastatic carcinoma, which is usually from a head and neck primary, and most often is going to be squamous cell carcinoma, and most often at level 2 of the lymph nodes that we talked about earlier. It's often cystic with central necrosis. And the most common site of occult primary is the oropharynx or the nasopharynx, typically viral associated. And when we're talking about viral associated, we're thinking HPV, right? So you can have squamous cell carcinoma, which is HPV positive, or you can also have squamous cell carcinoma, which is HPV negative. HPV positive is going to have a variable appearance, but often has a high nuclear to cytoplasmic ratio, and it's often non-keratinizing. And whenever you stain it with a P16, it's going to be block positive, meaning it's going to have strong, diffuse, more than 70% or more nuclear and cytoplasmic staining, which is what we're seeing demonstrating down here. So strong, diffuse, block positive P16 staining is what's going to happen in squamous cell carcinoma, which is HPV positive. Or you can use HPV-ish or PCR positive. Also, as I previously mentioned, you can have squamous cell carcinoma, which is HPV negative, which is often keratinizing or has a more conventional appearance. And the P16 is going to be negative or patchy, so the HPV-ish and PCR is also going to be negative because it's HPV negative. So instead of squamous cell carcinoma, you can have nasopharyngeal carcinoma, which can have a variety of appearances, such as squamous differentiation, and it's going to be mediated by EBV, so it's going to be EBER positive. Less common sites of origin are the thyroid, hypopharynx, and the larynx. And common diagnostic workup is going to be you're going to get a fine needle aspiration of the mass, and then pan endoscopy and imaging to identify the site of origin. All right, moving on, we've got HPV testing continued. So on the previous page, I did skip one page, and it was just a flow chart that I think would be easier for everyone to look at on their own on Kurt's Notes website. I don't see much utility in me just reading off a flow chart. I think that's going to be something that's going to be easier to grasp if you just look at it yourself and maybe take notes on it or read through it. And maybe you're not someone that learns from flow charts, so maybe you won't look at it at all. So in many instances, P16 is an adequate surrogate marker for high-risk HPV infection. And tissue specimens for non-cytology from metastatic squamous cell carcinoma of an unknown origin and an upper cervical lymph node should first undergo P16 IHC. And if it's positive with greater than 70%, greater than or equal to 70% nuclear and cytoplasmic staining with classic non-keratinizing morphology, then you know you're working with a metastatic squamous cell carcinoma that's HPV positive. So if it's block positive for P16, you can classify it as a squamous cell carcinoma that's HPV positive. Otherwise, you should do high-risk HPV testing with either in situ hybridization or PCR. For cytology specimens, there's no current widely accepted P16 staining cutoff, so high-risk HPV testing is recommended. And I did make my thyroid video based on Kurt's Notes, but never hurts to review papillary thyroid carcinoma. It's an absolute classic. Shows up a lot in practice. So PTC, we actually had a potential case today that we were discussing at Consensus Conference. So it's always good to review the features and good to be familiar with papillary thyroid carcinoma, which frequently metastasizes to the cervical lymph nodes. And lymph nodes can be very cystic, sometimes yielding scant epithelium. If you're just getting cyst fluid only but are concerned for PTC, try sending the cyst fluid for thyroglobulin levels. And if thyroglobulin is elevated, these findings suggest metastatic thyroid carcinoma, especially papillary thyroid carcinoma. And if you get epithelium, look for classic papillary thyroid carcinoma features, such as intranuclear pseudoinclusions, papillary structures with or without fibrovascular cores, powdery pale chromatin or nuclear grooves, squamoid cytoplasm, and that bubblegum colloid. So other neoplasms to consider in the neck region. So many salivary gland, thyroid, hematolymphoid, and soft tissue tumors can also present as neck masses. So it's best to often keep a very broad differential when you're working with lesions in the neck region. So please refer to the respective guides at on Kurt's Notes website for additional information for thyroid tumors, common systemic metastases like melanoma, lung, and breast, salivary gland tumors, soft tissue, and lymphoma. And last but not least, we have squamous cyst cytology. So it can be hard to sample the cyst wall, which can often lead to a false negative in cysts. So you can have a bland squamous cyst with cytologically bland squamous cells, which have round to oval nuclei, normochromatic, often abundant, dense, keratinizing cytoplasm, and they're often associated inflammatory cells if they've ruptured. You may see debris and macrophages from cyst lumen. So the main differential diagnosis for a bland squamous cyst is going to be your branchial cleft cyst. Remember, that's going to be if it's in the lateral neck near the sternocleidomastoid. Epidermal inclusion cyst, if very superficial. Lymphoepithelial cyst, parotid, patients with HIV, or thyroglossal duct cyst if it has a respiratory epithelium or it's midline. Moving on, we have squamous cell carcinoma. Oh, I'm sorry, not yet. Actually, we have squamous cyst with atypia. Next up, we have squamous cyst with atypia, which is worrisome but not definitive cytologic atypia that seem more than one would like for benign, but not enough for malignant. So it has you a little bit worried. You're thinking it's atypical, but you're not quite at malignant. You might have squamous cyst with atypia. So my threshold often depends on the clinical scenario. This is what Dr. Schaberg is saying. Higher in younger patients with no primary and lower in older patients with known primary. So that makes sense, right? If someone is older, they have a known primary malignancy, you're going to have a lower threshold to call something like this. However, if someone's younger, and you're going to have a much higher threshold, because if they don't have any primary, it's going to require a lot more to call this with atypia. And your main differential diagnosis for squamous cyst with atypia is degenerative or reactive squamous cyst and well-differentiated squamous cell carcinoma metastasis. And last but not least, we have squamous cell carcinoma, which is going to be hyperchromatic pleomorphic nuclei that we see here, often with a background of cystic, necrotic debris, and you may see mitoses. If it's keratinizing, you'll have large polygonal cells with abundant dense cytoplasm and irregular cytoplasmic extensions, which we commonly refer to as tadpole cells when that cytoplasm is drawn out and extended. And if it's non-keratinizing, think HPV mediated. Often more cohesive, uniform, higher nuclear to cytoplasmic ratio, and open chromatin. Squamous cell carcinoma often have cystic appearance with central necrosis. And also consider mucoepidermoid carcinoma if you see something like this, and look for goblet cells. Try to get a cell block to test for HPV if the primary is unknown. And that's it for neck lesions. I hope you enjoyed. Like and subscribe.